Good morning, everyone. On behalf of the organizing committee, I would like to welcome you to session number 2 today, the connective tissue disease, shared pathway and many faces. My name is Dr. Lutfi Sayali, rheumatology consultant in King Abdullah bin Abdulaziz in Prince Noura University Hospital. And with my colleague, Dr. Faiz Al-Hardi, the consultant of rheumatology in Al-Habib Hospital and Prince Abdulaziz Medical City in Jeddah. It's our pleasure today to moderate this session. The connective tissue disease is continue to be challenges with us with overlapping involvement and multi-system involvement. Today's session focused on the two important aspects, the systemic burden of the Sjogren's disease and the cardiac involvement in the systemic sclerosis, both highly relevant to our daily practice, and we are honored to have distinguished speaker who will share evidence-based update and practical insight. Our first speaker, it's my pleasure to introduce him, Professor Mohammed Al-Umair, who will be presenting the Sjogren's disease when it's more than dryness. Professor Umair is well recognized for his expertise in systemic autoimmune disease, and he will guide us through the broader clinical spectrum of Sjogren beyond Zika symptom. Professor Umair, the floor is yours.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. I would like to congratulate the board of the SSR for the successful conference and the scientific committee for inviting me to give this hopefully exciting talk. Especially in these days, Sjogren's disease is going into its golden era very slowly but surely. In the past, Sjogren's disease was a very neglected disease for mainly two reasons. It's underdiagnosed. Its manifestations are, to many people, not serious to take abrupt actions. And the second reason, there were no targeted therapies specifically for Sjogren. But now things are really changing, and I hope that the interest in Sjogren's disease over the next years will grow in our Saudi society. These are my disclosures, and these are gonna be my objectives. So first, I'm gonna take you into some basic science discoveries. There are many things that happened over the last 3 years, but I tried my best to select things that will lead change over the next few years. So this is a very comprehensive study that was published in Nature Communication, looking at phenotyping Sjogren patients based on their autoantibody positivity. Now, as you know, in the past, there was two main spectrum of the disease. One that is mainly T-cell driven disease and is associated with more fibrosis, more Zika symptoms, fibromyalgia, some neuropathy. And the other spectrum that is B-cell driven disease that has most of the extraglandular manifestations, arthritis, purpura, interstitial lung disease, MS-like lesions in the brain. And then you have the people that are in the middle. Now they selected 19 patients with 8 having SSA positive, 7 having centromere positive, and 4 having both, and compared them to patients who had Zika symptoms but no Sjogren's disease. And they did really a comprehensive assessment. So they did genetics, proteomics, cytokine profiles, they look at biopsies. It was like a state-of-the-art paper, despite that the sample size is very small. This is a table that summarizes the main findings of this table. So the first and very important finding, they found a very specific subtype of CD8 positive T cells. GZMB positive, GNLY positive. This is something that I don't know what does it mean or what is the main function of this cell, but they found it, the predominant CD8 positive T cell in all subtypes. They also found that centromere positive patients have more B memory cell enrichment. What makes also sense is patients who had SSA positive, so their Sjogren is closer to the lupus spectrum, had the interferon signature more activated, while patients who were centromere positive had more TGF-beta pathway enhanced. And this is for the future. So when you're gonna start doing trials and you're gonna, for example, develop a target for TGF-beta, you're gonna select only Sjogren patients who had centromere positive. While drugs like anifrolumab and the future ones that work on the interferon pathway might be more relevant for patients with Sjogren who are SSA positive. Also, fibroblasts are activated in all kinds, but some patients with the centromere pathway have more extent fibrosis in their biopsy, which all makes sense, really. This is a systematic review that again was published about 3 months ago, looking at some new biomarker, non-invasive biomarkers, mainly from the saliva. And you know the challenges of diagnosing Sjogren's disease patients. So first, the positivity of autoantibodies is not always present. So NA can be negative in about 15% of patients. SSA is only positive in about 60% of patients. Centromere even to a lesser extent. Then comes the minor salivary gland biopsy. And it's a very simple procedure, but logistically it's very difficult. It's not available in most hospitals, and you really need a good pathologist that reads the biopsy and understand what is happening there. And actually, in our institution, there are 2 people who reads the minor salivary gland biopsy. So we have the dental pathologist in our dental hospital, and we have a specific dedicated pathologist that reads these biopsies. And now we're doing correlation between the 2 pathologists and looking at their inter-observer agreement. So they found some metabolic signature, increased level of alanine, of taurine is associated with inflammation in the salivary gland. You have beta-2 glycoprotein elevation, you have some microRNA, and maybe one day Sjogren disease diagnosis would be from just a drop of saliva. This year marks the Independence Day of Sjogren's disease. So it was called Sjogren syndrome. And whenever you say syndrome, it makes it a lighter disease of less significance, less importance. It's always dependent on the main disease. You treat the lupus, the Sjogren might improve. You treat the RA, the Sjogren might improve. So an international committee of physicians, but also engaged patients, looked and worked on changing major areas in how we look at this disease. So first, they looked at the prevalence of Sjogren's disease and different autoimmune diseases, and you could see about a third of myositis patients have Sjogren's disease, 20% of spondyloarthritis patients, and again, this is an under-recognized area, despite many studies are evaluating cohorts of patients with Sjogren's disease, but you rarely see the percentage. 15% of systemic sclerosis and lupus have Sjogren's, and 10% have RA in addition to that. And you could see that sex is an important factor for having Sjogren's disease. So women play a major role, or the sex, female sex gender or gender have a high impact of increasing the risk of having Sjogren's disease as an associated disease. Then they tried to find a new name, and I'm really glad that they did not commit the same mistake of GPA and eGPA. I'm not sure, how do you tell your patients that he has GPA or eGPA? Do you still use the old names? But there were suggested names, and then there was a clear agreement between the task force from the physicians and the patients on Sjogren's disease. This is a figure generated by a very nice app called Notebook LM. So I summarized what are the major changes. So Sjogren's syndrome term does not exist anymore. It is replaced by Sjogren's disease, and the abbreviation is uppercase S, lowercase j, and uppercase D. And when you write the term, you can use all kinds of O's, so it does not make a difference. There is no difference between the disease when it is alone or in combination with another disease. And the term secondary was dropped, and now we have the term called associated. So it gives a higher value, a higher importance for the disease compared to calling it Sjogren's or secondary disease. So when you say secondary, it means that disease developed because of the primary disease, but it's actually two distinctive diseases that affect the patients in totally different ways. Now, there are many agents. I'm just going to focus on two agents that are very promising. This is ianalumab, which is an anti-BAFF antibody. Its two clinical trials, Neptunus 1 and 2, have shown statistically significant improvement in clinISDI. This was presented in the last ACR. And Novartis has announced in its website that its product is approaching in very serious steps the approval as a first dedicated biologic for Sjogren's disease. We have also napicolumab, which from its study, Dahlias, was published in Lancet, November of 2025, showing significant improvement in all outcome measures, including the ESPRIZE. So the ESPRIZE look at fatigue, patient global assessment, and pain, while the ESSDAI looks mainly at extraglandular manifestations. Now, with the 2030 healthcare transformation and the value-based healthcare model, when you look at outcome measures, now the health authority is trying to select what outcome measures reflect value, and it's usually a comprehensive assessment, and you have multiple outcome measures. But what is really important for you who had taken special training or have been engaged in value-based healthcare programs is that it is important to select outcome measures that matter to patients. So for example, let me give you the most clear example on outcome measures that matter to patients. If an osteoarthritis patient is going for knee replacement, the outcome that is most important for the healthcare system and the treating orthopedic surgeon is the success of the surgery, the range of movement, the wound, the absence of complications like infection or deep vein thrombosis. But for patients, it's a totally different history. They want to pray, they want to climb the stairs, they want to walk further. And here you see the discordance between what a physician wants and what a patient wants. I'm just going to do for you a quiz. Can you scan the barcode, please? يلا ما دام السمعة لاصقة لاصقة يا أبو محمد. So which one of the following is the most affected function in patients with Sjogren's disease? Five seconds. Okay. طيب. Can you go back to the slides, please? The Sjogren's Syndrome Foundation is the largest foundation supporting patients with Sjogren's disease. And they have a very organized structure, and their website is very useful. Unfortunately, it's not translated to Arabic, but they give really practical advices, because many of these advices coming from patients and their treating physicians, so they help patients. And they just published, again, maybe 4 years ago, the largest survey in the literature on Sjogren's syndrome. And I'm just going to take you into some important components, and I'm going to put arrows on what I see relevant, but all of these points are really important for you to remember when you're going to see your next Sjogren's disease patient. So these are the demographics, and if you could see in the bottom of the table, most of these patients were having primary Sjogren's disease, so there was no associated disease. And the other thing, you see a third were officially diagnosed with fibromyalgia, which most likely this is an under-diagnosis. Now, it's a very important taboo that it's very difficult to evaluate and address. One of our colleagues now is publishing a study on rheumatoid arthritis related sexual dysfunction, and it was a challenge to convince patients to participate, but the number is very depressing for me as a physician. And because you cannot ask them directly, you cannot engage them on this discussion, and at the same time, when you diagnose them with a problem, there are limited resources to help these patients, except if you have a specialized urogynecologist in your hospital. So you could see the intimate life, the hobbies, which are these important things for the patients. Can they perform what they like to do in their daily living? Job, career, adjusting to work, overall mood, relation with family.
Prof. Umair, it's 2 minutes remaining.
Yeah. So many of these patients do not go to weddings because they cannot tolerate talking to patients for a long time. They cannot stay on their social media as much as they want because of the dryness of their eyes. These are the medications, and you could see here 20% only of these 3,000 patients were ever on a biologic. And of course, you know, so rituximab, ما في إلا واحد. طيب. But you could see here, about 2/3 of these patients ever use alternative therapy. So when you have more alternative therapy than approved medications, you have a big problem. And half of them are on antidepressants. Here is a cut down of the cost of patients with Sjogren's syndrome or disease at the current moment. Dental care, prescription medication, healthcare appointments. Alternative therapy is half of the prescription medication. And finally, this is the cost. What these patients need to do in order to survive with their disease. Now, in our association, we have a specific program for Sjogren's disease, and it's mainly to provide pilocarpine. And it's very unfortunate that many hospitals in the MOH does not have pilocarpine. In the private, they don't have pilocarpine. So the association is actually providing disease. But I'm really asking you to really go to your formulary committee and request that this medication should be introduced. Tell them that you have this amount of patients who have this problem and you need this medication. But of course, patients with Sjogren's disease are benefiting from all kinds of services. So we provide them physiotherapy. Now we have a specific pathway for them in the Fibromyalgia Association. So we take care of fibromyalgia, of Sjogren's and fibromyalgia in a specific way. But there are huge unmet needs in the healthcare system. So it is your role to be their advocate and to ensure that these patients have a better care in your hospital, especially the dental care. Again, it's a huge unmet need. They spend thousands of riyal in very poor clinics, if they accept even to treat them. So I would like to conclude by saying that we are really going into a golden era in Sjogren's disease. RA, I think we're really plateauing, and I'm not seeing any new product in RA, but in Sjogren's disease, you're gonna see a lot of things, and they're gonna cost a lot of money. We have many studies that are helping us phenotype patients, and this will help in adjusting treatment better and having this drug approved. We hope to really have more studies on Sjogren's disease in Saudi Arabia in view of disease activity, organ involvement, quality of life, and even qualitative research. And in our institution, we have a cohort of patients, and we're happy to collaborate with any colleague who have any idea and to conduct a study on their patients, and we can recruit our patients into their project. Thank you.
Thank you very much, Prof. Umair. Our next speaker is Dr. Khalid Al-Jahani. He will discuss the heart and systemic sclerosis, clinical spectrum and outcome. Dr. Khalid Al-Jahani is Assistant Professor and Chairman of a Cardiac Science Department at King Saud University. Welcome, Dr. Khalid.
Assalamu alaikum, everybody. Just a quick question for Prof. Muhammad. Is living in Riyadh a risk factor for Sjögren? Because I have dry eyes from there. So thank you so much for the organizing committee. My name is Khalid Al-Jahani. I'm an interventional cardiologist, the chairman of cardiac science department at King Saud University. I have to say, all my joints feel great being surrounded by this excellent rheumatologist and being in the rheumatology conference. Can I have my slides, please? So today I'm going to talk about the systemic sclerosis, albeit a very rare disease to a cardiologist to see, but there are a lot of manifestation that can involve the heart, and it's unfortunately very lethal. So, going next. So this is the outline of today's talk. I'm going to spend some time in reviewing the etiologies and some of the new terminology that involves the cardiac manifestation. And then we'll go about how to screen, because most of this spectrum is usually asymptomatic. Once they have the symptoms, it's often lethal. And then review some evidence on the treatment of such diseases. Usually, thank you so much. Now I can read it from my screen. Some of the management which usually interact between the rheumatologist and the cardiologist. So the clinical burden of this disease, first of all, the mortality. I think nephrologists with their medication did a good job, because initially with the scleroderma renal crisis was the major lethal disease or cause of death for these individuals, especially because of the ACE inhibitor, but things shifted as they have better treatment, and probably we're doing not as good as our colleague in nephrology. There are a new terminology called primary heart involvement has emerged since the SRC came down, because better treatment. Now we see, I think it's top 3 as a cause of mortality in systemic sclerosis patients. And it's often, as I mentioned, is silent. And that's where it plays a role for screening, because these symptoms, when it shows in these individuals, the mortality goes as high as 70%, 75% in certain literature. So once the patient has symptoms, their 5-year life expectancy is very significantly drop. Discussing a few slides about the etiologies of why the heart is involved. Well, the heart is a muscle. So anything that happened to the skeletal muscle can affect the heart. Although the heart is a very special muscle, I have to say, since I'm a cardiologist. But the etiologies that we can see, it's an interaction of different pathophysiologies of dysregulated immune system, a microvascular disease, what happened to the vessels in the skins and the body happens to the vessels inside the heart. So there is a Raynaud phenomenon that can happen that causes ischemia and reperfusion injury, and the recurrence of this will lead into the spectrum of disease that we see in these patients. Of obviously the inflammation, and then the tissue fibrosis and adverse remodeling that will lead for worse outcome. So the trio of damage that we see is the vasculopathy, inflammation, and fibrosis. As I mentioned, the myocardial Raynaud's, as vasospasm happens, it causes and induces ischemia, and then heals with fibrosis. Obviously, some secondary causes, because systemic sclerosis, as the name implies, systemic, so that it affects all the organs, and all these organs can lead into exponentiate the symptoms in the cardiological system, causing worse outcomes, especially interstitial lung disease, the pulmonary arterial hypertension, and obviously scleroderma renal crisis. And some of the medication are, when used in high dosages, can also induce cardiotoxic effect. And in one survey, looking at the sudden cardiac death that happened to this individual, the majority of them, sometimes we find the reasons. As you can see from the slides, coronary artery disease that happens in any individual, systemic sclerosis might be accelerated. They have a pathognomonic features in the histopathological feature. It's usually patchy, not as concentric as in the regular coronary artery disease. Also, the spectrum goes from cardiomyopathy, myocarditis. It affects also the valves, causing some valvular dysfunction, which potentiate also the cardiotoxic effect. When we don't find anything on the autopsy, usually arrhythmia is to blame because the conduction system is very sensitive, especially tachyarrhythmia. And this is just a summary of the extension of things that nowadays they call primary heart involvement that can extend from the pericardium, myocardium itself, and the conduction system, which is usually lethal, especially if it was associated with a tachyarrhythmia like ventricular tachycardia, and vascular disease causing the microvascular dysfunction and recurrent vicious cycle of ischemia. And this table shows the prevalence, being the arrhythmia the most common in the reported cases we have, and also the pericardial disease. Rest, the more malignant ones like myocardial dysfunction, LV dysfunction, are least prevalent, but are more lethal, especially when they are in the later stage of the disease. So we mentioned that, but I'm going to go across it quickly. And as I mentioned, that it's a vasospasm that happens into the microvascular, which induces ischemia. The myocytes are very sensitive to ischemia. Once this happens, it will induce healing and fibrosis, and that will lead into what is known as myocardial Raynaud's phenomena, that will lead into fibrotic changes that is pathognomonic, found in the autopsy studies, to be patchy, not as the one we see in the regular coronary artery disease that we treat on a daily basis. There is no specific systemic sclerosis therapy for it. We treat it as a regular coronary artery disease. So we give vasodilators, we give statin therapy, we give aspirin, and we give beta blocker. However, we know that beta blocker can potentiate the Raynaud's phenomena, so it might actually have a worse outcome. The most preferred, and maybe you have a different opinion, you can teach me about it, is about the carvedilol being the most effective and what you like as rheumatologist to be giving for patients specifically with Raynaud phenomena, because any other non-selective beta blocker can cause Raynaud phenomena to become prominent, i.e. it can affect also the myocytes. There is a rare, but often in a situation of a crash and burn situation, something called scleroderma cardiac crisis, when an acute LV dysfunction happens due to the process of vasospasm, which often, if treated with supportive therapy, can be have a good outcome, especially in a specialized cardiac center where you can reverse that with supportive measure, because that's what you would treat these patients with supportive measure, and even transplant if they didn't refractory had it. And it's luckily reversible, because we believe that the pathophysiology of this is a diffuse, extensive vasospasm in all the coronaries leading to this dysfunction. Conduction defects, it can extend from a simple PR prolongation in the electrical system, conduction in the ECG, to as bad as ventricular arrhythmia, secondary to fibrosis, which we hate as cardiologists because I think it's difficult to treat. And advanced modality of treatment nowadays to ablate these foci of fibrosis can help reduce the worst outcome of ventricular fibrillation. But the most common finding that you would see, that's why we advocate for doing an annual ECG, is any form of block or frequent PVCs, which can be detected by Holter monitor. So the tachyarrhythmia, which will appear like this, if it's too fast, it will lead to compromising the blood pressure, and maybe it will lead to death and ventricular fibrillation. Again, 12-lead ECG and Holter monitor is the way to go. Pericardial involvement is usually benign. However, symptomatic in about 5 to 16%. Usually it will lead into asymptomatic pericardial effusion, rarely develop into pericardial effusion and tamponade. And if it become recurrent, it might lead into constrictive pericarditis, which is very hard to treat. An important note, which is always, it's always nice to have colleagues that I worked with, colleagues who are wise, because sometimes they have a reflux. You have an effusion that is big, let's drain it. If the patient have pulmonary arterial hypertension, it's not really wise to do it, because it will cut the circle of compensation, and the patient, when you draw the pericardial fluid, might go into acute suicidal effect because that RV is contained with this fluid is protective. So once you take that protection, the patient can crash immediately after drainage. So not all fluid to be drained, that's the point. And the usual treatment is usually an anti-inflammatory like Brufen and the colchicine for acute pericarditis. For recurrent, difficult to treat constriction, maybe pericardiectomy is the way to go in advanced cardiac centers. Heart failure, unfortunately, luckily it is very uncommon. However, when it happens, it's very bad and it's associated with worse outcome, i.e. mortality. The spectrum extends from diastolic dysfunction, which is nasty, but not as bad as the reduced LV function or HFpEF, heart failure with preserved LV function. And HFrEF, which is heart failure with reduced ejection fraction, that is usually bad and associated with worse outcome. The treatment is the 4 pillars that we usually do and treat, and it's something we call the 4 pillars: beta blockers, spironolactones, diuretics, and SLG2, like Forxiga and Jardiance, and also the Entresto, what we treat any regular patient with heart failure with reduced ejection fraction. Most important in these patients is the beta blocker, as I mentioned, because of the side effect and the potentiation of Raynaud's phenomena. Myocarditis, which is usually detected by positive troponin in the right patients, and obviously with the excellent modalities of diagnosis like MRI, usually happens, and the way I think about it, as I mentioned earlier, is if the myocytes is active in the skeletal muscles, it can happen to the myocardial muscles. It's usually associated with certain serologies. And that's what I found on my literature review. I don't know if we use it or not in our clinical practice. But troponin will indicate the presence of myositis based on also cardiac MRI pathognomonic feature, which will go through the scoring system that we used. The usual treatment for acute myocarditis is usually supportive and then immunosuppressive therapy, steroids and MMF. And important to mention also the cyclophosphamide is a treatment for myositis. However, when used in high dosages, it can cause a rare, which is something I've never seen, but I don't know if an expert from the audience have seen, a hemorrhagic myopericarditis, which is usually serious. It's described in the literature. I myself, I've never seen such, or seen a patient on a high cyclophosphamide dose. So how do we usually approach these patients with suspected primary involvement with an established diagnosis of systemic sclerosis? As well, in cardiology, when we don't agree on a diagnosis, we create a scoring system. I'm sure you have the same way of thinking. So there are a consortium that got together and actually met that include cardiologists, include pathologists, and include obviously rheumatologists being the champions of this disease. They sat together to formulate a scoring system that helps people to screen and to at least direct the patient to a specialist where it will do. And with the validation, I think it was published in 2025, and validation is quite actually good, with a sensitivity of up to 80% and specificity of 96%. I'm going to walk you through some of the, that's the sheet that you usually see when you have a patient with scleroderma. The weight is from above to down going less. Clinical features is the least, where you get a point if the patient had, or 3 points, depending on the chart, and then you calculate it. Anything above 11 would signify a high probability of the diagnosis. So the things to focus on is the clinical feature, serum biomarkers, right side heart cath showing elevated pressures that is not explained by anything else, ECG and echo, and obviously MRI and biopsy. So for the clinical, it has the least weight because are non-specific and it can be due to any other finding. For the biomarkers, we usually have 2 in the scoring system, the ProBNP, which is usually elevated when the heart fails, and the troponin, obviously. And again, it's a very low weight because it's non-specific. The BMP, the way I want you to see BMP, if it's negative, there is no heart failure. If it's positive, it's not necessarily that there is a heart failure. So it has a good negative predictive value. And often the cutoff 130 is the usual that we use for this scoring system. Troponin is, we're getting better and better with our serology in troponin, and it's very specific. So once it's positive, it can signify an active myocardial inflammation. There is no specific antibodies for cardiac involvement in scleroderma, systemic sclerosis. However, it can associate with these antibodies with the pulmonary arterial hypertension, myocardial involvement, myocarditis and pericarditis specific to these autoantibodies. Right heart cath, if it's not explained by any other underlying disease, an elevation can give 4 points. ECG, it's AV block of its different variation, mostly high-grade AV block like second-degree and third-degree AV block, and having an ectopy and sustained, non-sustained ventricular tachycardia based on an Holter monitor. As you can see, as we go up, the weight of the score gets higher. This is, as I mentioned, an annual 12-lead ECG is usually recommended to check for this, although a Holter is not also a bad idea because it can give you a duration. An ECG, it takes 6 seconds, but you want to have an extensive duration to catch anything of the abnormal arrhythmia. Echo, the appearance of, the only downside about what they used here, there is now something called GLS in the newer echo machine. They didn't use it. However, it has a good specificity to indicate early changes in the LV function, better than just waiting for the LV to be reduced and to have it as a significant LV dysfunction. And it is easily non-invasive, readily available, and it can be requested routinely by cardiologists, and we recommend to do it annually for these patients, irrespective of their symptoms, as a way of screening. Cardiac MRI, it actually has the highest weight in terms of scoring. There is specific finding that can signify the appearance of systemic sclerosis and the susceptibility of the diagnosis being high. Again, and luckily it's a non-invasive and it doesn't have radiation to it. Biopsy is the gold standard and often done with the right heart cath, where you take a piece of the right side and then send it to microscope, and obviously seeing is believing. Once you see the inflammation, then you can confirm the diagnosis. And I think I reached to my concluding slide, that screen early, because we know once these patients have symptoms, they will not live long. And they will, up to 75% will will die within 5 years, which is the highest mortality I've ever seen on any diseases that I treat by myself. If the key is, if the muscle is inflamed, the skeletal muscle, then the heart is, probably is. And use a scoring system, because it can help you direct the patient for advanced therapy. And the goal is not to treat symptomatic. We are good in treating symptomatic patient, but to catch the asymptomatic patient to prevent them from the worst outcome and mortality. Thank you so much.
Thank you, Dr. Khalid. You finished in time, exactly. So now we will move to the third topic in our session 2, connective tissue diseases. And we look at another phase, which is the neuroimmune interactions in autoimmunity, the brain-joint axis. It will be presented by Dr. Islam Shusha, who is the chairman of Neuroimmunology and Headache Department, King Faisal Specialist Hospital and Research Center. Welcome, Dr. Islam.
Good morning, everyone, and thank you, Mr. President, for your kind introduction. And I would extend my thankful to the organizing committee for their kind invitation to participate in this elite conference. It was a good opportunity to meet some old friends and also to make new connections as well. So I don't have any relevant financial disclosures. However, we might highlight on the off-label treatment therapies. Just to start with some engaging questions before we go to the lecture itself. So Beagle sign on a spine MRI would indicate, if you would appreciate your participation, maybe raising hand. If you think it will indicate neurosarcoid myelopathy, you can kindly raise your hand. Okay, good. So if you think it's indicating Behçet disease of the spine, raise your hand. A few hands are there. And then if you think it's anti-MOG myelopathy, so also raise your hand, please. Okay, so we have few answers for the Behçet disease. The second one, the commonest neurological presentation in Sjogren disease, and I learned today it's no longer a syndrome. Thank you for the updates. So what do you think? If you think it's fatigue, mental fatigue and physical fatigue, raise your hand, please. Fantastic. If you think it's neuropathy, raise your hand. Good. Myelopathy. Okay, no supporters for BNC. And the last one, have you heard about Susak syndrome before? Yes. Few hands. No. Okay, so give us an opportunity to raise the awareness about this entity as well. So the last question before I move forward, so as a neurologist, I'm definitely interested in the brain things. I would like to ask you, among your practice, how many of you screen the neurological presentation or neurological manifestation when you see patients with rheumatological conditions? If you do, please raise your hand. Okay, so we have very few percentage, and that's where it comes, the title of my talk, What Happened to Monday. So this movie came a few years ago that with the lady that she delivered a subtopulate, that me and 7 identical girls, and she named them according to the weekdays, like from Sunday to Saturday. And then they missed Monday. And this is actually what happens when you approach a rheumatological patient. You screen definitely for the skin and the joint, which is the most common presentation. And then you would have the lung, the heart, the kidney, and the reproductive system sometimes if you're approaching antiphospholipid syndrome, and maybe some blood discrepancies as well. But we miss the neurological manifestation. We do not screen for them when we see rheumatological patients. And it comes to the opposite from our side. As a neuroimmunologist, when I see any patient that they present with CNS demyelinating or inflammatory diseases, I screen for the other mimickers by default because I have to make sure that I'm dealing with a primary CNS disease, inflammatory disease, or it is just a presentation of a systemic inflammatory disease. So please keep in your mind Monday and look for it. So I'll share a couple of cases, but before we move into that, as part of this subtopulate, the 7 identical girls, it comes also to the shared manifestation between all the rheumatological platform diseases. They have the similar presentation on the brain, on the spinal cord, in addition that the vessels involvement, and it goes without saying, and you know better than me, that there are a lot of other systematic shared manifestations, either with the skin, with the joints, or with the antibodies, or even with the peripheral involvement that sometimes make it difficult, as my colleagues highlighted, that might be an overlap or interactions between, or have 2 diseases like the SLE and the Sjogren disease as well. So I'll start with case number 1. I have a 57-year-old female that I evaluated her in 2021, that she presented initially with imbalance, diplopia, and then visuospatial defect, and shortly later that she had short memory loss and some behavior changes. She was evaluated initially in another hospital, and they done the imaging, which I will share shortly, and the CSF analysis, as you can appreciate, they're mild pilocytosis, but high protein, indicating that there is ongoing inflammation. Glucose were normal, and the oligoclonal bands were unremarkable. What comes at this age to me at the beginning is that I want to make sure that I am not dealing with autoimmune encephalitis or paraneoplastic disorders. So I advised them to pulse her with a steroid, which showed some improvement, but we screened for the autoimmune encephalitis panel, the paraneoplastic panel, they were all unremarkable. MRI spine was clean, rheumatological workup was also normal, but we picked up in the CT CAP that she has something called GEST, which is gastrointestinal stromal tumor. So I thought this might be an autoimmune encephalitis, like with underlying tumor, although that the panel was negative. However, when I reviewed the imaging, I identified that some of the juxtacortical lesions, but there was a corpus callosal enhancing lesions, looks like the snowball. So I said, okay, so well, there is something else that here I have to consider, having this pathognomonic lesion. So I reached out to the neuroophthalmology and I said, well, I would appreciate if you can screen this patient with fluorescein angiography because I am suspecting some sort of small vessel vasculitis. And the fluorescein angiography came supportive the thought, although the patient has never complained of any visual symptoms. And accordingly, I made up the diagnosis that this is not an autoimmune encephalitis, this is a Susak syndrome. Susak syndrome, it's one of the autoimmune small vessel vasculitis that patient present with either cognitive symptoms, headache, and snowball lesions in the corpus callosum, in addition to screening of the retina. So they might have some plaques on the branch of the retinal artery, some occlusions as well, and the third triad would be the ear involvement, sensory neural hearing loss. To have a definite diagnosis, so you should have completed the three triad together, which is rarely that they can come together, maybe only 27% in the patients, but also there is a probability that you might have only two supportive findings, definitely with the brain, with the symptoms and the lesions, but with the retina, you do not require the symptoms, but the findings, the silent findings on the fluorescein angiography would support the features. I chatted with her oncologist that they were taking care of the guest, and he said that he is planning to go with imatinib, which is a tyrosine kinase inhibitor, and I felt that would be enough for the patient. I do not need to move to any immune therapy. However, in other scenarios, those patients would treat them with a steroid, and then the steroid-sparing agents along the spectrum was azathioprine with the mycophenolate mofetil, rituximab, etc., if we need. 2016 was the final updated European criteria for Susak syndrome, and this is what I have highlighted a minute ago regarding the presentations. So moving to another case, a 25-year-old male that he present with paraparesis, weakness of bilateral legs, progressed over 2 weeks with some sphincteric involvement, and also they showed response to steroid over 10 days. He mentioned in the history that there was a right-sided uveitis 6 months ago, and there was no any other supportive features for other autoimmune conditions, other with the rheumatological symptoms, or the mimickers like MS or neuromyelitis optica. Spinal fluid analysis showed polycytosis with polymorph in addition to high protein and positive oligoclonal bands. The rest of the workup for the autoimmune conditions were unremarkable. So looking to the brain and the spine imaging, there was no clear lesions, some mild leptomeningeal enhancement, but as you can identify, there is a high signal intensity lesion in the spinal cord, but if you can look at it carefully, there is a hypo intense signal within the high signal of this lesion. So, and this is how it looks like on the axial cut. If you can identify it, that goes with the Beagle sign, which is can present on up to 40% in patients that they have Behçet disease myelopathy. So I chatted with the rheumatology. The condition was confirmed I'm sure that you don't need this tabulation. However, those are examples of the common presentation of neuropathy. Headache comes on the top of the list, and then you have the involvement of the brain stem, the spinal cord, and to a lesser extent, the peripheral involvement. It's worth to mention here that is a very common practice that I found, that when they approach any patients with brainstem, the first thing that comes to their mind, oh, that could be a Behçet disease. Brainstem can be reflecting Behçet disease, but please be careful and diligent. It is not always Behçet disease. I just reviewed a patient 3 months ago that he was referred from another center, has been treated for 2 years as a neuropathic based on brainstem isolated lesion, and he's on a steroid as a thiobrin with no response. The lesion is the same, with a red flag, and then turns out that this patient has low-grade glioma. It has nothing to do with inflammatory conditions. Other lesions that you can identify with the other locations, with the juxtacortical lesions, with the basal ganglia involvement, and as I mentioned, enhancing lesions, and also the Bagel sign that was prescribed a few years ago with my colleague from Mayo Clinic, a Turkish neurologist, Uğur Uglu. And this patient was maintained in azathioprine and a steroid. One supportive feature that you might need in the practice as well, the central vein sign. So in 2024, central vein sign was added as a diagnostic criteria for relapsing remitting multiple sclerosis. However, this lesion is not only specific for multiple sclerosis, it has been studied in other neurological conditions, as you can see from this study that published in Annals of Neurology, that the highest percentage it was among neuropathic diseases. This is an imaging reflecting or identifying the central vein sign, which is the accumulation of inflammatory lesions across the demyelinating lesions, and how it can differentiate between non-specific lesions like migraine, etc. A third case that also have a 39-year-old female that was evaluated a few years ago, and after the COVID vaccine, the patient presented with numbness, weakness, and a picture suggestive of myelitis, and a month later, she had a significant physical and mental fatigue. The CSF analysis was showing polycytosis, negative oligoclonal bands, but also high protein, and the ANA SSA came back positive. So having the myelitis picture, having the disabling physical and mental fatigue, which can be part of the MS presentation, but also the negative oligoclonal bands, the positive antibodies, it raises a flag that this might be an MS-like presentation for a Sjögren disease. So as you can identify the lesions, they are typical in their location, in their geography, in the topography, typical for multiple sclerosis. I chatted with the rheumatologist, and we decided to go for the lip biopsy, but it was inconclusive. There was some inflammatory cells, but they were not the typical ones that we have or we see in Sjögren disease, and we decided to start the anti-CD20 rituximab and follow up the patient that they might have any further systematic symptoms down the road. Examples of the other presentation of Sjögren disease, peripheral neuropathy, but as we mentioned earlier, this is not the commonest, and this is like a mispractice. The commonest is the mental and physical fatigue. So other examples of the Sjögren disease involvement, it can involve the bitemporal area, which can be one of the differential for autoimmune encephalitis, in addition to the myelopathy as well. However, sometimes there might be an asymptomatic antibodies that they can show up with MS, and if you can see from this tabulation, the ANA with the different titrations that you can identify the percentage that can be from 1 up to 20%, like asymptomatic antibodies that can show up with MS. And it goes without saying the same for neuromyelitis optica, that they might have an overlap with the diseases or associated diseases or asymptomatic antibodies as well. Case number 4, this patient that I evaluated in 2020, and she had the history started from 1997, that they were always located to the same area. She always relapsed in the brainstem. She didn't have any further lesions across all of those years. She was maintained in glatiramer acetate, and there was no response. So when I reviewed the patient, reviewed the images, relapsing in the same location, that raises a red flag for sarcoidosis. I call it relapsing in situ. So the patient relapsing in the same location, either with the spinal cord or the brain itself, that raises a flag for sarcoidosis. So I told the patient, as she is new to my practice, maybe I just need to make sure that this is the correct diagnosis, and I sent for the ACE level, it was normal. I sent for the CT chest, which showed some lymphadenopathy, and unfortunately, this patient disappeared like for 3 months from my practice despite the following calls to trying to reschedule her. And then I received a call from the pulmonology team that the patient is admitted. She had pleural effusion, she has pleurisy, myocarditis, and they figure out that they are dealing now with sarcoidosis, and they are reaching out to see what treatment she should be. And we have a multidisciplinary discussion with the rheumatologist, myself, and I fought against the anti-TNF, and final decision was to start her an anti-IL-1, which should be safe and will not cause any demyelination. There is an overlap between MS and sarcoidosis. This paper came out a few years ago, and they screened 10 patients that they have biopsy, definite biopsy for sarcoidosis, but they have typical MS presentation with no red flags for neurosarcoidosis. So they can coexist. And at the same time, this is a study that they looked into neurosarcoidosis CSF analysis, and it showed that there was no any increasing in the ACE level in the CSF, but 50% in the serum, and also that we might have a lower glucose, and we don't see that in multiple sclerosis. Sarcoidosis is a great imitator. It can present with all the typical, atypical presentations, and cranial neuropathy would be a very common presentation, and you can see the entire spectrum is there. The second would be myelopathy. So we have identified different patterns like this butterfly, or involving the multiple enhancing area, similar to what we can get in TB as well, and this involvement of linear enhancement in the brain, and we have in the spinal cord what we call it the trident sign on the axial cut for neurosarcoidosis myelopathy.
2 minutes, Dr. Islam.
So perhaps you might need that as a diagnosis for definite neurosarcoidosis. Either we will have a biopsy, or if it is not, so you should have the symptoms, and then it's 2 supportive features, either with the scan or with the serology itself. Different examples of the treatment for neurosarcoidosis. I usually advise to avoid the anti-TNF to not to get any demyelinating diseases. I'm not sure if we have enough time for the last case, but I'll skip that. Just like the moral, this patient has SLE, presented with psychosis after the steroid. They involved us because they thought it is SLE cerebritis, but the patient had auditory manifestation. When we have auditory manifestation, it's favoring steroid psychosis, but not SLE cerebritis as well. And I might come to the conclusion. I think you guys have answered those questions. Beagle sign indicating Behçet disease. Physical mental fatigue is the symptoms of neurological symptoms, and I think I hope that I got the opportunity to highlight about Suzak syndrome. and thank you for your attention. And this is a good source for neurorheumatology diseases. And keep your mind that always look for Monday when you evaluate your rheumatological patients. Thank you so much.
Thank you, Dr. Islam. Now, kindly, I ask our valuable speakers here, please come to the stage. If we have a few questions. Prof. Muhammad, Dr. Khalid.
Yes, thank you very much. To congratulate all three speakers on the excellent talk. I would say this is one of the best sessions in the conference. My question to Professor Omer, it's good to see Sjogren has been elevated in its status to a disease, but I'm still wondering why they had to introduce the term associated. We don't do that with the other overlap syndromes, overlap when we have two different distinct diseases. So it kind of seems still it is being given a second class. So can you explain why they wanted to keep the associated and not just have two diseases that have been overlapped?
Now, basically, the complexity of patients living with rheumatic diseases that they can have multiple diseases at the same time. And the decision making at that time would make it a complex decision. So as I implied in the lecture, that when you mention secondary, it says that the second disease is most probably linked to the first disease. But now we could see that despite that most rheumatic diseases have similar genetic predisposition, but the different pathways that are activated really require assessment and management of each disease individually, and then you try to find the common pathway that could treat both of them at the same time. But I think associated disease makes Sjogren's a more independent entity rather than it's always a secondary phenomena.
Thank you.
Yeah, next, please.
Assalamu alaikum, and thanks for the nice presentations. My question will be directly to Dr. Islam. We have currently a case of primary Sjogren syndrome with a seronegative myasthenia gravis that is relapsing almost 2 times within the last 3 months, requiring aggressive therapy like plasma exchange. The moment plasma exchange is done, she would recover and improve, but she was hit hard by different immunosuppressive therapy, rheumatology, neurology on board, but she was not improving. So have you dealt with similar cases of seronegative myasthenia gravis with primary Sjogren syndrome, and what is your treatment approach in such cases?
Thank you for the question. Myasthenia gravis is not my specialty. I do central inflammatory neuroimmunology that might be fit for the neuromuscular team. However, what I can say is that nowadays the treatment of myasthenia gravis has really expanded beyond the off-label therapy. We have more advanced medications, like for example the anti-complement 5, either with the eculizumab, the ravulizumab, that they can work for refractory myasthenia gravis cases, in addition to the FSNRN, the FcRn antagonist, the efgartigimod, that can be considered. So I would advise maybe you can reach out to a neuromuscular colleague. I think they might have a better input than myself.
Thank you. Next, please.
My question is for Dr. Khalid. I'm not sure whether he's here.
We can't hear you.
Dr. Khalid is here. Thank you for the amazing talk.
Dr. Khalid, unfortunately, I didn't know he is not here. So, Prof. Ahmed, if you have any question.
Yes, I have. Dr. Amer, nice to see you again. Dr. Amer, I have a number of patients. I want to ask you about the diagnosis. The problem, these cases, I'm talking about like 4 patients, they have the severest dryness that you can see, both eyes and mouth, even documented in the ophthalmology hospital. But the problem, there is no diagnosis, including biopsy. We did biopsy. So my question, do you think we have a problem? For example, Dr. Shusha, I think he presented a case, possible Sjogren, but the pathology was not consistent. So do you face this? Do you think our pathologists not experienced or something? Because all these patients have biopsy and they were, investigated fully for malignancy, for any other cause. But the biopsy came to be negative. But at the same time, we are treating them as Sjogren because we don't have any other diagnosis. Thank you.
Thank you very much. This is one of the challenges that I face almost on a quarterly basis when I see a patient who has severe Zika symptoms, severe dry eyes with corneal ulcers and severe dry mouth where they lose their teeth at a younger age, and you do autoantibodies, you send them for a minor salivary gland biopsy, and then they come up with a negative biopsy. And they have, again, severe fibromyalgia, severe fatigue. Now, this kind of patients, I really discuss with them the probability of having the disease. So on paper, they don't have Sjogren's disease, but should we treat them like a Sjogren patients? And I usually tell my colleagues is that pilocarpine is a non-specific medication, so you could use it. And we don't overestimate the effect of pilocarpine, but some patients, they improve dramatically is that their gland is stunned and then improves, and they stop the pilocarpine after 6 months a year because the dryness has disappeared. And some of them, they go on to full dose, 3 to 4 tablets per day, and no response. And you have some patients who actually have dry uterus, not only vaginal dryness, dry uterus. You treat them with pilocarpine, and then they conceive after 6 months or 1 year of being on treatment. So what I would advise if any of us face such a patient is give them a probability, because some patients with inflammatory arthritis, we're not really sure if they have inflammatory arthritis, but yet we still treat them with DMARD and even biologics. But at the same time, you can give them all of the measures for pilocarpine. I have one patient who I even elected to give her belimumab, and she did not have a response. Then I told her you can get a second opinion. So at least give them the benefit of the doubt and give them these secret drugs as much as you can, and lifestyle modification. But for now, we don't have enough to say that, for example, if a negative minor salivary gland biopsy is in this patient, means doesn't have Sjogren syndrome. You cannot say that. We don't yet know how much this is sensitive and specific. But you have to treat the patient anyway, and have a multidisciplinary management with the ophthalmologist and of course dental specialist.
Thank you. Just last comment to Dr. Umair. What's your experience? As you mentioned, we have only rituximab as a biologic. We try it in Sjogren disease. What's your experience with rituximab in patient with Sjogren's?
Now, there are many drugs that have different responses. And when you look at a clinical trial, you're looking on the effect on a group level, not on a patient level. So, for example, if you give rituximab to 100 Sjogren's patient, you're going to see some of them, the dryness have dramatically improved, and some of them, it did not touch them. So On a group level, you would say significant, not significant, but on individual level, you would not know unless you see it. I'm not a big believer of hydroxychloroquine, but some of the patients, they tell me, my dryness improved the hydroxychloroquine. So I have to believe that because yes, it is a subjective finding, but these patients are suffering every day. So any minor change, they will really feel it.
Thank you. So the last question, Dr. Muhammad.
My question to Dr. Islam, do you do MRI spinal cord for any patient with suspected inflammatory brain disease?
Do we do MRI spine for?
For any patient with suspected inflammatory brain disease like vasculitis, demyelination, or autoimmune disorder?
Yes, so screening MRI spine for demyelinating lesions, even if the patient they never had any symptoms suggestive of myelitis, it's one of the supportive features. In addition, that we look into that to complete the diagnostic criteria, for example, for multiple sclerosis. But what I need to add on that, maybe Prof. Mohammed can comment on that. Sometimes if we are in a gray zone, if we are dealing with a pure CNS inflammatory conditions, or this presentation is part of rheumatological conditions, sometimes I screen the peripheral systems. For example, Sjogren's disease, or even the SLE or sarcoidosis, you might find on a nerve conduction study supportive features even if the patient didn't complain of any peripheral neuropathy, for example. So I use that as one of the tools, that sometimes as a screening tool to support if we are in a dilemma of this, if we are dealing with one of the rheumatological conditions. I'm not sure about your practice. Would you consider this for patients if they have significant dryness, but there is no other supportive features for Sjogren? Do you screen them for other systemic symptoms, even if it is asymptomatic?
Now, for Sjogren's disease, we usually do not screen if a patient does not have any manifestation. Okay. Saying that, many patients with Sjogren's disease have silent lesions in the brain, have very mild ILD. So if the phenotype is a B-cell driven disease with a very high SSA, so we have patients with a SSA of more than 600. These are the patients that you might, even if the guideline is not telling you to do so, that you might screen asymptomatic systems. But on a routine basis, usually we don't.
Thank you. So thanks for our valuable speakers. Thanks for the audience for interactions and for comments. We have to conclude our session at this time, and we will move to the third session. Thank you.